All right, so today we're going to dive into a really fascinating and honestly perplexing condition called Median Arcuate Ligament Syndrome, or MALS for short. It's a true medical puzzle. The diagnosis is tricky, the cause of the pain has been debated for decades, and as you'll see, the solution isn't always so straightforward.
I want you to just imagine something for a moment. What if every single time you ate a meal, instead of feeling satisfied or full, you were just hit with these waves of severe, debilitating pain? Nausea, bloating. This isn't some hypothetical. For people suffering from MALS, this is their daily reality. And the symptoms are just awful. It starts with what doctors call postprandial pain. That's just a fancy way of saying severe pain right after eating. This leads to something called food fear, which is exactly what it sounds like. Patients become genuinely terrified to eat because they know the agony that's coming. And when you combine that with nausea and vomiting, you get significant unintentional weight loss. For some, even just exercising can trigger this pain.
Now, here's where the puzzle really kicks in. From a purely anatomical standpoint, the ligament compression that we see in MALS is surprisingly common. Studies show that as many as 24%, almost a quarter, of the general population has this physical characteristic.
But, and this is the absolute core of the mystery, less than 1% of those people ever actually experience any symptoms. So the huge question for doctors has always been, why? Why do some people with this exact same compression suffer so terribly, while the vast, vast majority feel nothing at all?
Well, this uncertainty leads to just immense frustration for patients. You can imagine. As the source material points out, when the first round of tests for common stomach problems comes back negative, a lot of these patients are told the pain is all in their head. They get slapped with psychiatric diagnoses or they're labeled as non-compliant, all while their very real, very physical suffering just continues. So, okay, we've got a condition that's really hard to pin down, with this giant gap between who has the anatomy and who actually has the symptoms. Let's start by breaking down what's physically going on in the body here.
So what is MALS? It all comes down to the median arcuate ligament. Think of it as a fibrous band of muscle at the base of your diaphragm. In some people, this ligament just sits a little too low or it's a bit too tight, and it ends up pressing down hard on two really critical things, the celiac artery, which is a major highway for blood to the gut, and the celiac nerve plexus, which is like a massive complex switchboard for all the nerves in your abdomen.
For decades, the medical community had a prime suspect for what was causing all this pain. And that suspect was all about blocked blood flow. The thinking was really simple and intuitive, right? It was seen as a basic plumbing problem. The ligament was like a foot stepping on a garden hose, the hose being the celiac artery, and it was just choking off the blood supply to the stomach and intestines. This lack of blood flow, called ischemia, was believed to be the source of all that pain. Simple as that.
And this idea really dominated the field for years. After the very first surgery to release this ligament was done back in '63, a really important paper in 1971 by two doctors, Stanley and Fry, pretty much cemented this blocked blood flow theory. It became the standard explanation for MALS for a whole generation of doctors.
But, like any good mystery, the obvious suspect, well, it wasn't the whole story. As researchers started looking closer, they began to realize the real culprit might be something else entirely. It might be all about compressed nerves.
See, the blocked blood flow theory started to show some serious cracks. For one thing, the human body is pretty smart. When a major artery gets squeezed, it often just grows smaller secondary vessels. We call them collaterals, to bypass the blockage. And what's more, when scientists actually ran tests, they found no lack of oxygen in the gut. They did endoscopies and found no signs of tissue damage from ischemia. The evidence just wasn't adding up.
And this led to a massive shift in thinking. The focus moved away from that vascular theory, where pain was from a lack of blood, to what's called the neurogenic theory. The idea here is that the pain is actually caused by the overstimulation of those compressed nerves. The spotlight basically moved from the artery to the nerve bundle right next to it.
So, to put it another way, the new theory sees MALS not as a plumbing problem, but as a wiring problem. That ligament isn't just stepping on the blood supply hose anymore. No, it's stepping directly on the gut's alarm system. That dense bundle of nerves that's responsible for signaling pain and controlling how your stomach functions. Okay, so if the main cause is nerve compression, how do doctors actually diagnose and treat this thing? Let's walk through the process.
The diagnostic journey is really a process of elimination, then confirmation.
First, doctors have to rule out all the more common GI problems with tests like endoscopies. Then comes the key test, a dynamic duplex ultrasound. This isn't just a static picture. It actually measures the blood flow through that artery while you're breathing. And if that comes back positive, a CT or MR scan can be used to get a clear picture and confirm the anatomical compression.
And this dynamic is the real aha moment in the diagnosis. Here's what happens. When you breathe out, your diaphragm moves up, which tightens that ligament and squeezes the artery. This causes blood to shoot through that narrow opening at incredibly high speeds. We're talking over 200 centimeters per second. Then, when you breathe in, the diaphragm moves down, the pressure is released, and the blood velocity goes right back to normal. That dramatic change is the classic textbook sign of MALS.
So, the primary treatment is surgery, and thankfully, it can usually be done with small incisions, laparoscopically. The goal is to go in and simply cut or divide that tight ligament. But now, with this new theory in mind, the surgeon's focus isn't just on freeing the artery. The absolutely crucial step is to also clear away all the fibrous tissue around that celiac nerve plexus to give that irritated alarm system the space it needs to finally calm down.
But even with a leading theory and a really targeted surgical approach, the story of MALS, it doesn't end there. The mystery isn't totally solved just yet.
Take a look at these typical surgical outcomes. You can see that the surgery is often very, very successful. About 85% of patients get immediate relief from their symptoms, which is just a fantastic result. But for about 15% of patients, the symptoms either come back after a while, or even worse, they never improve at all. And this is the final, frustrating piece of the MALS puzzle.
These little case snapshots from the source material really highlight the challenge. I mean, you can have a patient with all the classic symptoms and a perfect-looking scan who only gets a little bit better. You can have someone else who feels great right after surgery, only for the pain to suddenly return. This variability just hammers home how critical it is for doctors to select the right patients for this surgery in the first place.
And this really brings us to the most important lesson learned from all the research. Even with our best, most advanced scans, there is no specific finding, not how tight the compression looks, not how fast the blood flows, that can reliably predict which patients will actually get better after surgery. The biggest challenge that remains is just figuring out who is truly going to benefit.
Which leaves us with this final, really thought-provoking question. For both the doctors and the patients who are navigating this condition, the challenge is just immense. How do you solve a problem that you can physically see on a scan, but you can't always prove is the true source of someone's pain? That central uncertainty is what makes MALS one of medicine's most enduring and most human puzzles.